And so last we're going to hear from Dr. Sheetal Vora at Atrium Health Levine Children's Hospital. And she's going to be continuing along similar discussions to tell us about how we may be better able to use the feminist perspective in order to improve the journey to diagnosing rheumatic conditions. Dr. Vora.
Great, and thank you for that nice introduction, and I hope everyone can hear me. I'm very fortunate to have a great team, and I thank the Arthritis Foundation for allowing us to present our work today, titled Follow the Yellow Brick Road, Using the Family's Perspective to Improve the Journey to a Rheumatic Diagnosis. I'm a pediatric rheumatologist, and I work at Levine Children's in Charlotte, North Carolina. So, I really wanted to highlight all the societal unrest and injustice that for me started when COVID occurred, and just we all can, I'm sure, relate to even what's happening in the world today. But just with the George Floyd movement, with COVID and how it disproportionately affected a lot of our Native American population, you can understand the unrest and the injustice that has occurred. The pictorial is helpful just to help understand that, while we all hope for equality, we need to have the right tools in order to have a level playing field. And so equity may help that, but what we really need is to be liberated and finally to be included so that we can be part of the actual game and really lend the voice, and for all people to be able to lend their voice. So I'm very fortunate to have a phenomenal project and team members, including Sarah Mabus, who's our program coordinator, Talia, who is our quality improvement coach, Jasmine Ryan is our senior data analyst, and then Layla is our PEDS research coordinator, and then we're supported at Wake Forest with the Quality Patient Reported Outcome Center. So this slide is to just reinforce or kind of highlight to all of you that Charlotte, while it's a very urban city, the areas with the highest crime rate don't always equal the areas of our safety net clinics. And so what you can see here is in the red circle, this is actually our highest crime rate area. But what's interesting is that the safety net clinics that service pediatrics, there are 3 of them, North Park, Myers Park, and Elizabeth, actually don't even fit into that highest crime rate area. And Myers Park and Elizabeth are actually located in some of the poshest areas of Charlotte. So for me, really, every project starts with a narrative, and I need to have a why and a passion for what I'm doing. So it really began with a preparation for another grant opportunity, where we identified patients that were diagnosed by a PCP, and they had 1 or more symptoms that were linked to a rheumatic condition. And this is regardless of whether they had even seen a rheumatologist. And we found a little over 2,200 patients. These are pediatric patients that actually met that criteria. Now, approximately 2,000 of these, 86%, were seen in 4 of our Atrium Health clinics. And these include the Myers Parks, the North Point, the Elizabeth, and Biddle Point that I mentioned and showed on the other slide. But what was very fascinating, if you can hit the advance button, is that only 5 or 0.2% ultimately saw an atrium rheumatologist. That's shocking, out of the almost 2,000 children. And 858 of these kids were actually seen once at our just sole pediatric clinic, Safety Net Pediatric Clinic, Myers Park, which is located within 10 minutes of our hospital and in one of the poshest areas of Charlotte. So it's unknown really if these children were seen by a pediatric rheumatologist outside of Atrium, or what barriers may have prevented them from actually being seen by a subspecialist. But what it did highlight to myself and our team is that we've got to get it together, we've got to collaborate. And that's really what's going to be essential in ensuring that these children get not only pediatric rheumatology care, but timely care. So really the aim of this initial project was to prevent morbidity and mortality related to rheumatic conditions in this underserved PEDS population. And our focus again was on the prompt and accurate identification and then subsequent treatment of their symptoms or diagnosis from these 4 Atrium Safety Net clinics. And I just want to take a moment to mention that our team had already successfully implemented another project by using a specific tool that we're asking the providers to fill out prior to referring to our clinic. And this then helped us to better triage those children who were being referred. And this was not just Atrium-wide, this was our entire community, including hospitals that were outside of our system. We serve about a 450-mile radius here in Charlotte, and we asked folks who referred to us to fill out this important tool so that we were able to triage effectively so that children who were seen could be seen in a timely manner. We wanted to make sure we saw the right patient at the right time. So this specific project then helped us to hone in to improve health equity. So our proxy measure was really that we wanted to see a 10% increase in accurate referrals for those pediatric patients from these 4 Atrium Safety Net clinics. But what happened is this really launched during COVID, and we were unable to go into the clinics other than the Myers Park Pediatrics Clinic. Because of COVID, we were limited where we could go, and so we focused our efforts at Myers Park, and a 10% increase from that about 858 patients that they had seen in the previous slide was that we would then have to see 17 children, 17 additional patients who had rheumatic symptoms referred from the Myers Park Clinic in order for us to achieve this aim. So using the model for improvement science and quality improvement tools, we then had interventions. We used PDSAs, or Planned Use Study Act tests of change, and that really led us to some wins. So the first one is really under plan, where we educated the providers at the Myers Park Clinic on our auto text referral tool. We presented at provider meetings, making sure that they knew how to use it and to enter the important information if they felt like a child had a symptom that was associated with a rheumatology diagnosis. And then we actually got those referral coordinators to be involved, such that a child, before they sent the referral, the provider had to fill out the information needed in the tool. So this is really focused at provider and staff education. The second intervention was on timely huddles, and this is where we were increasing the number of the appropriate referrals. And what we did here is we were involved in monthly meetings with the providers at the Myers Park Clinic, and from this we collected data on monthly referrals and tool usage, and then we provided continuous feedback. So this was also very helpful, and all of these things happened in concert. And the third was really visual cues, whereby we put up visual reminders in the clinics where the providers practice at Myers Park to know that we have this referral tool available. It not only served for them to fill out the important information, but it allowed them to ask the appropriate questions that a rheumatologist needed to know to ensure that they were seeing the right patient and that we could get the child in at the right time. We placed these cues not only as posters in the workroom, but also as signs on the keyboard. We then surveyed providers, including residents that were working at Myers Park, as well as their attendings, to ask them if this was helpful. And then we continued to maintain and update the visual tools. So this is showing some data. This is a run chart, which shows the cumulative referrals from the Myers Park Pediatric Clinic. And you can see here on the y-axis, this is the number of patients, on the x is the months, and the red line is our median, and the green is our goal. Going up is preferred, and you can see that during the course of the project, when we started, it was really 0. And as we continue to employ these interventions and PDSAs, we were able to reach 15 patients that were eventually referred from Myers Park. We didn't get to 17, but I think we can all agree that this was still a wonderful improvement, so that providers at Myers Park Pediatrics were able to use the tools, understand about what is important during a referral to a rheumatologist, and would help us see the patient at the right time. So here, what we noticed after we completed this portion of the project is that we were really missing the voice of the patient and the family and getting the full stakeholder experience. And so we really wanted to spotlight the importance of the patient to provider dialogue. What we did is recorded a video with one of our real patients explaining her journey to diagnosis. And really in this provider script, we highlighted our value. I wanted to make sure that the providers that we were going to send this out to understood that we really cared about them. Burnout and well-being was real during this time, and we wanted to make sure that the providers did listen and they did connect the various symptoms a child has to a complex condition. We also demonstrated that patients and families' cultural and socioeconomic barriers exist, and that ultimately that affects their referral to be seen by a pediatric rheumatologist in a timely manner. And if this was not considered, this could result in additional emergency room trips and hospitalizations in order to make the diagnosis. And finally, we wanted to recognize that all of the providers really want to do their best, but we just have limited time. And by utilizing this tool and really helping hone in what a rheumatologist thinks is important, they were able to not only educate themselves, but get the important information that is needed for our patients. So this really led us to our proposal for this particular grant. We wanted to make sure that care access, was not hindered by social determinants, but we needed to find out what they were and how we could overcome those barriers. Because we knew that this led to frustrated families, especially if they have social determinant of health factors and their ability to really access a specialist. And our team's prior work really on improving timely access held the potential to improve attention to both the diversity, the equity, and the inclusion for all these children to be seen by a pediatric rheumatologist if they needed one. So the importance of this project is really to directly understand the journey a child and their caregiver undergoes when they're experiencing a health-related symptoms that could lead to a rheumatic diagnosis. It specifically highlights the potential disparities of social determinants of health, and really it could limit a timely diagnosis and negatively impact the child's health outcome. And to our knowledge, this is the first study of its kind in the U.S. to characterize these experiences of the children and their families to a diagnosis of a rheumatic condition. So our objectives are first to characterize the care-seeking experiences of these children and their caregivers to a diagnosis of a childhood rheumatic condition, specifically highlighting on these social determinants of health, including biology, social environment, physical environment, and health services. And our second objective is really to identify factors to inform intervention to support the timely referral and the diagnosis of a rheumatic condition in our urban center. Next slide. So our design, this is a qualitative study. We use semi-structured interviews, and then we'll have a thematic analysis. We will also obtain data through chart abstraction, and we will collect demographic data through a pre-interview survey. The inclusion criteria include the caregivers or children that were diagnosed from January 1st of 2020 and onward, so as to limit bias. Since this is interview-based, we wanted to make sure that we had children that had confirmed rheumatic and or hypermobility conditions, and they could be seen at any of our 4 Atrium Health Levine safety net clinics, or they could have been diagnosed through a hospitalization. And the eligible diagnoses are really based on a pediatric rheumatologist's expert opinion and satisfy the published criteria for a specific rheumatic diagnosis. Exclusion criteria are children who don't have a rheumatic disease, and we're hoping to get about 20 caregivers of children with confirmed rheumatic disease and or hypermobility during our study time period. So current state is really that we're almost close to getting IRB approval, which I think is going to happen today. And we've already identified our eligible families, and then we hope to get started on this work. And that's it. So thank you, and I look forward to any questions or suggestions, and I always welcome collaborations. And again, thank you to the Arthritis Foundation. This is really important work for my team and our community. Thank you.